So with this, I start. I'm very grateful to Conceptual Anesthesia for giving me this platform so that we can mutually share the information of interest, which will be useful for your exams as well as your practice of medicine. So here I am Dr. Saif. I'm a consultant in critical care medicine in the Department of Critical Care at King Hamad University Hospital, Bahrain. And I have few degrees to my name, and I'm certified intensivist since last 12 years, post-MD. So here we are going to cover essential points about Guillain-Barré Syndrome. As you know, this is a disease which can debilitate anyone. Anybody can be affected. Anyone who has mild or infection or had vaccination or any kind of thing may have Guillain-Barré, and you may have your relatives around who could be giving the history of Guillain-Barré syndrome. So I had met, before I joined the medicine, I met about 2-3 people who had Guillain-Barré and how they managed a whole course of disease inside hospital and in ICU on ventilator. And later when I became a critical care physician, I actually saw about more than 100 patients of Guillain-Barré syndrome. So it's very common CNS disorder, and every anesthesia or intensive care trainee should know about this disease. It's very crucial topic for all the trainees in emergency anesthesia and critical care. So as you know, this is a disease of nerves, and nerves could be motor nerve, sensory nerve, autonomic nerve, cranial nerve. So all types of nerves could be involved, but mostly motor and sensory nerves are involved. Okay, and it could be demyelinating. Most commonly, this is the demyelinating disorder, acute inflammatory demyelinating polyneuropathy. So basically, demyelination. So you know what is myelin? Myelin is a covering. It is an insulation around the nerve fiber. Okay, as you can see here. So this is your nerve fiber, and around which there is the proper insulation, and then there is the root node of Ranvier and the myelin fibers, myelin sheath. So myelin sheath can keep the nerves intact and conduction intact, and there will be faster conduction in the myelinated nerves. But what happens when there is demyelination? Then these nerve fibers get exposed, and the action potential and the nerve conduction becomes very slow and blocked at various levels. So that you would see in electrodiagnostic testing when you are going to do on a patient. But grossly, there will be nerve conduction issues, and due to that, the patients will develop myopathies, and they will develop paresthesia, various sensory problems, motor problems, and if autonomic nervous system is involved, it could be autonomic dysfunction as well. And in the rare variants, there could be cranial nerve involvement as well. So 4 types of nerves are involved variably, but most commonly the motor and sensory nerves are involved. Okay, so this is why we have various variants of GBS according to nerve involvement and according to involvement of various muscle groups. So various about 12 or 13 variants are have been described of GBS, and I think most commonly we have 2 or 3 variants. Most commonly, if you ask if at your level, you should know axonal variant and demyelinating variant, in which demyelination is more common, axonal is less common. Okay, so what happens in axonal? Axonal means there is a damage to the axon itself. So there will be damage to the inner part, that is this part. Okay, so nerves will be involved. Nerves means inside nerve fibers will be involved. And if the myelin is only involved, that is okay. In about 95% of cases, there is a demyelination, but this is self-limiting. Over a period of time, depending upon the degree of damage, it will take some time to recover all the damaged myelin slowly by the body itself. Okay, so there will be again regeneration of the myelin, and disease will disappear. But during the time when all the myelins are lost, you will have a lot of complications, and that is the goal of critical care, to prevent the complications happening and wait for myelin to reappear over around the nerves. Okay, so this is why there is a role of critical care. So we are going to discuss all of about the Guillain-Barré syndrome, the management part especially. I'm not going to discuss pathophysiology. I'm not going to discuss about various variants which you can study in any medicine book. I'm going to just discuss about the clinical features and critical care management. Okay, so that you will be very confident in managing such cases in ICU as an anesthetist in the operation theater, as well as an exam going students. You have to be aware about the management of Guillain-Barré syndrome, which is going to be asked in various exams in critical care or anesthesiology. All right. So how to recognize the Guillain-Barré syndrome? So this is something which is very interesting. So there are some cardinal features of Guillain-Barré which you have to understand, and you should be thorough with all kinds of features which are quite common, which are quite interesting as well. Okay, the first and foremost is the rapid onset of muscle weakness. So the patients usually present to emergency department with this particular complaint, that doctor, I developed sudden loss or sudden decrease in using my muscles in my lower limbs and upper limbs. Okay, so I'm not able to do certain functions. So this is going to be key clinical feature, the rapid onset of muscle weakness, which often presents with sudden. This is very important. It's not gradual, it is sudden and progressive. So it will starts in one muscles and one group of muscles, and then it will develop over a period of time. It will involve more and more muscles and more group of muscles. All right. So this is the progressive muscle weakness, and it typically starts in the legs. Okay, so it starts in the lower limbs first, the feet, and then distal muscles and then proximal muscles all will be involved. So from the feet towards upper torso, and it will involve hands, and then later it will involve even the diaphragm. All right, so it starts from downwards to upward. Okay, so it is the ascending weakness, ascending flaccid paralysis. So it starts from downwards and goes to involve upper limb as well. There is another cardinal feature which is areflexia. So areflexia, or you can say reduced reflexes also are possible. So there will be deep tendon reflexes. If you test in the lower limbs or upper limbs, there will be reduction of reflexes. Sometimes there is complete absence of deep tendon reflexes, especially the knee jerk and ankle jerk, which is quite common finding. Then the third cardinal feature is paresthesia. As you know, paresthesia means altered sensation. So sensory nerves are involved here, and due to which in severe cases, the patient will be reporting tingling sensation over hands and feet, and also numbness in the extremities. Okay, so feet and hands, your patient will be describing that they are feeling, they are not, the sensory part is not intact. So they will be feeling numbness, they will be feeling quite altered sensation. Okay, and they won't be able to localize it properly. All right. So, and sometimes there will be allodynia as well, altered pain sensation. So all these you can see under paresthesia, which is very common. And lastly, if the weakness is very severe and it ascends to involve the respiratory muscles and diaphragm, which is the main respiratory muscles is the diaphragm. 75% of respiratory function is done by the diaphragms. So if suppose diaphragm is involved, then the patient will develop hypoventilation, will not be able to breathe well, and they will accumulate the carbon dioxide, leading to hypercapnia, respiratory acidosis. Okay, and later they may have respiratory arrest, complete respiratory arrest or apnea. So such things are very dreadful and very complicated, and the mortality is going to be very high.